Thank you, Mr. Chairman, for the kind introduction, and I'd like to thank the ICS Scientific Committee for the opportunity to present our study, and I'd further like to acknowledge our multitude of co-workers, and in particular, Dr. Anna Rosa-Miller for her support and collaboration. This is my disclosure. This study received an external research grant from the MS, but we have exclusive control of the data and editorial rights, and it is registered with the Clinical Trials Registry. How do I advance the slide? Mini slings have been introduced to reduce complication, and there were favorable early results, and we then set out to evaluate in a randomized controlled trial, the outside-in transobturator sling and the mini sling, and we intend to report the 5-year results. So we included patients who required surgery for stress urinary incontinence, and in particular also included those that required concomitant prolapse surgery and those with treated detrusor activity. And an important exclusion are those with low closure pressure and low leak point pressure, and we use standardized outcome measures. The details of the power analysis is in our abstracts, and the mini slings was tensioned to snug. At baseline, we observe balanced characteristics between the two treatment arms and confirm adequate randomization. With regards to subjective cure rates, we observe no statistical difference between the two treatment arms across all post-op time points, including when we account for missing data, assuming them to be failure. With regards to objective cure rates, we observe, again, no statistical difference between the two treatment arms, even when we take into account those that has failed surgery, of which there were 4 in one arm and 5 in the other arm. With regards to patient-reported outcomes, we use standardized questionnaires, and we observe a sustained reduction in urinary incontinence as reported using the short form of ICIQ-UI, a difference that far exceeds the minimally important difference, and there were no statistically significant difference between the two treatment arms across all post-op time points. With regards to overactive bladder, we again observe an improvement, no statistical difference in sexual outcomes, an improvement in incontinence impact, and an improvement in global impression between the two treatment arms. Our study adds substantial data to the comparison between obturator slings and mini slings, and confirm the comparable efficacy and functional outcomes at medium follow-up of 5 years. What we already know is that there has been concerns with regards to efficacy, and that this data also further suggests that mini slings inherits the advantages of the obturator slings, and it appears to be as good as the standard outside-in sling at 5 years. Thank you for your attention.
Paper is now open for discussion.
Yes, Jerry Blavis from New York. Thank you for an excellent presentation. My special thanks to you and Professor McGuire for continuing these long-term follow-ups. I know this isn't the first 5-year study that this group has presented, and it's to be commended. I have questions about the complications. The efficacy, the protocol is wonderful, and the results are wonderful, in my judgment, for efficacy. How did you go about, I didn't see anything about complications except for sexual dysfunction. How did you track complications? Did you do them prospectively or by recall? Because I think that practically everybody acknowledges the comparable results from a lot of these slings in terms of efficacy. The major controversy revolves about complications, so I'd like to hear more about the complications and how you assess them.
Thank you very much. Due to the practical time limit, I wasn't able to show the entire slides. We do measure the complications extensively. So we have clinical time points where we invite patients to come back. For those who cannot come back, we will post out questionnaire or phone them to evaluate whether they have repeat surgery or whether they went somewhere else, and also ask specific question about groin pain. if we are not able to assess ourselves. I do have some additional slides in case there were questions, but I don't know whether I could show them on the screen. But if we didn't see any voiding dysfunction except
Can you
2
please see
cases
these
out of
slides?
220, out of 221 each on one arm, defined urodynamically, there were no sling division, there was 1. Growing pain, we observed up to 6 weeks, people who reported them and take pain relief, and it did not lead on to surgery for them. And at a long-term follow-up, I think there were probably 2 or 3 in each arm that reported a degree of growing pain, but didn't require further intervention. So it was DINDO 1 or ICS, CTS classification of a lower category. With regards to repeat surgery, there were 5 in one arm and 4 in the other arm. There was no statistical significant difference. All of them required retropubic sling. With regards to mesh exposure, I think there were 1 each. One of them had a concurrent anterior mesh repair. The other one, there were no other mitigating factors. There was some banding that we observed, particularly with the obturated sling. If I recall, it was somewhere in the region of 4 or 5. And we specifically asked them whether they have any symptoms. So they're asymptomatic, elicited by doctors who examined them. Obviously, that parameters cannot be assessed on a phone call because they require digital examination. With regards to sexual outcomes, I intended to show the pre-op, post-op sort of thing, and the best I can show within the time limits is using the PSQ-12. With regards to sexual pain, I don't recall any reporting of it. I accept that there was some attrition with the data at 5 years with anything. So from the data that we know, we stand by what we just said. I don't know if I covered all the potential complications that you were interested in, but yeah. Thank you.